My name is Whitney Chase. I'm a nurse practitioner at Vanderbilt University Medical Center. I work on an inpatient team that serves patients with hematologic malignancies, and I'm pleased to present today on the management of acute toxicities in patients undergoing high-intensity chemotherapy for acute leukemia. So acute toxicities are many in this patient population, but today we're going to cover 3 complications that they face, including infection, disseminated intravascular coagulation, or DIC, and tumor lysis syndrome, or TLS. So my objective for you by the end of this presentation is to be able to identify risk factors for these toxicities, to discuss the associated signs and symptoms, and to develop evidence-based plans for the treatment of infection, DIC, and TLS. So the first complication we'll cover is infection. So febrile neutropenia is defined by its 2 parts, the fever and the neutropenia. So it can be a single oral temperature greater than or equal to 101 degrees Fahrenheit or 38.3 degrees Celsius, or a temperature greater than or equal to 100.4 degrees Fahrenheit or 38 degrees Celsius for at least 1 hour, with an associated absolute neutrophil count of 500 or less, or an ANC of 1,000 or less with a predicted decline to 500 or less in the next 48 hours. So this is the most common complication of cancer treatment, and it can be deadly. So febrile neutropenia is seen in over 80% of patients undergoing chemotherapy for acute leukemia, and fever may be the only sign or symptom of infection that these immunocompromised hosts can mount. So we're able to identify infection less than 50% of the time when these patients fever. So because morbidity and mortality is high for patients undergoing high-intensity chemo, we must have high suspicion for infection when patients fever or have changes in vital signs or other clinical changes. And these findings need to be treated as infection until proven otherwise. So patients with acute leukemia are at high risk for infection by the very nature of their disease and its effect on the immune system, making infection a potential presenting symptom for these patients. During induction, consolidation, and even maintenance, they continue to be at high risk for infection. So once we start treating them with high-dose chemo, we expect to compound these immunologic deficiencies by causing them to become severely neutropenic. So purine analogs are particular offenders. We can also see mucositis, which disrupts the natural barrier we have throughout our GI tract, putting patients at high risk for direct infection of the sores or for translocation of bacteria. So the same is true for the cutaneous barrier of patients who develop rashes or wounds, and certainly central lines or other tubes are potential sources of infection. So listed here are some common indications of infection. And again, fever may be our only indication of infection when the host is immunocompromised. So, and as with many diagnoses, we have to have a certain level of suspicion for that condition to be able to diagnose it. And as people who care for patients with acute leukemias, we should always have some degree of suspicion for infection when our patient just doesn't seem right. So working up the infection, history and physical can be helpful in elucidating a potential cause of infection. If your patient has a localizing symptom, like what we saw on the previous slide, they might be able to tell you about that and to guide your workup, or maybe they don't have any symptoms, but they tell you that their grandchildren visited the other day and, maybe had runny noses or other respiratory symptoms. Other comorbid conditions may help guide your evaluation. The patient's underlying cancer diagnosis, do they have ALL or AML? What therapy are they receiving? Have they had any recent antibiotic exposure? Do they have any indwelling devices that may pose an infection risk? Do they use recreational drugs that may have exposed them to something? Physical exam may show mucositis or rash, drainage from port sites, or coarse lung sounds. We would want a CBC with differential to know what their white blood cell count is and their ANC. This information kind of helps inform our level of risk for the patient and helps inform our antibiotic choice. and the setting in which we treat them. Like if they're outpatient, do they need to be admitted? 2 sets of peripheral blood cultures and blood cultures from any central lines are recommended, as is urinalysis. So these emboldened ones are kind of must-dos, and the others might be considered on a case-by-case basis. So culturing any wounds that might be present, throat culture, stool culture, chest X-ray, or abdominal imaging might be obtained based on patient signs and symptoms. As we head into the fall and the winter, I certainly, we're starting to see more respiratory viruses. So if we identify a bacterial infection, it's most likely to be gram-positive, but gram-negative bacteremias are a little more common than gram-positive bacteremias, and they're more likely to be deadly, particularly if they're multi-drug resistant. So while we wait for our workup, we should start empiric broad-spectrum antibiotics. So they should be started within 1 hour of onset of the fever, the so-called golden hour, and started ideally after cultures have been obtained. But antibiotic start should not be delayed if we're unable to get blood from the patient, or if they're unable to produce a urine sample, or kind of whatever the hang-up is. Monotherapy with an anti-pseudomonal beta-lactam is what's recommended. Such as cefepime, piperacillin, tazobactam, or carbapenem. And listed here are some of the typical starting doses for patients with normal organ function. So, and certainly your patient and their allergies or other medications would influence your antibiotic choice. And your institution's antibiogram can be really helpful in informing that choice as well. For example, at Vanderbilt, where I work, piperacillin had the best pseudomonal coverage until a couple of years ago, and now it's cefepime. So some indications to potentially add vancomycin to that would include hemodynamic instability, skin or catheter site infection, concern for MRSA pneumonia, and gram-positive bacteremia before final speciation and susceptibilities are available. So the recommendation for initial treatment of neutropenic fever is pretty clear, but what's not so clear is the recommended duration of therapy if an infectious source is not identified. So prior guidelines suggested continuing treatment until neutropenia resolved. However, de-escalation has been shown to be safe and to reduce the potential harms of unnecessary or prolonged antibiotic exposure. So we should consider peeling back antibiotics in 48 to 72 hours after the onset of fever. If the fever resolves, infection is not identified, and the patient is clinically improved, or at least stable. So as we should, we have a tendency to fixate on fever as indicative of infection, but if we can attribute it to another cause, like the disease itself and so-called tumor fever, or maybe we identify a DVT, or maybe it's drug-induced, maybe there's immune reconstitution if we're in the count recovery phase. These scenarios might also prompt consideration for de-escalation of antimicrobials, even if fever persists. So most infections are likely to be bacterial, but viral and fungal infections are also certainly possible, especially given the degree and duration our patients are neutropenic. So more in-depth discussion of specific infections and their treatment is kind of outside the scope of this presentation, but I think it's worth saying that patients with AML are at particular risk for invasive fungal infections, and in general, invasive fungal infections are on the rise. So looking for fungal etiology may be important for patients who continue to fever and generally look sick, kind of despite broad-spectrum antibiotics. So serum testing of galactomannan and aspergillus PCR can be helpful in this immunocompromised population. 1,3-beta-D-glucan serum testing can be helpful, but is not specific to one fungal species and may not be detected in the presence of some fungal infections, including Cryptococcus. So histoplasma antigen from the urine or blood can be used for the diagnosis of suspected disseminated and acute pulmonary histoplasmosis. Blasto could also be considered depending on where your patient lives. It's most common in the Midwest, South Central, and Southeastern United States. Kind of similarly, coccidoides is prevalent in the Southwest United States, and that would it's recommended to test urine and serum antigen for that one, as both with blastomyces and coccidoides, the serum and urine testing isn't felt to be particularly sensitive, but can kind of help point to infection with one of those organisms. So bronchoalveolar lavage for further pulmonary testing may be considered, although is obviously more invasive than taking blood or urine. So imaging can also be helpful in pointing to a diagnosis, as we have on the right here some pulmonary aspergillosis and histoplasmosis in the CNS. So the old adage rings true here, an ounce of prevention is worth a pound of cure. So with antimicrobial prophylaxis, we've been able to reduce morbidity and mortality associated with high-intensity chemotherapy regimens. But as we all know, these patients still get sick. So current recommendations for first-line antimicrobial prophylaxis, antibacterial, is fluoroquinolone for people who are at high risk for febrile neutropenia or those with profound prolonged neutropenia, which includes our acute leukemia patients being treated with high-intensity chemo. So these are our only oral agents that cover Pseudomonas, which is why they are preferred. And levofloxacin is considered superior to ciprofloxacin in preventing febrile neutropenia and bacteremia, so would go for that when possible. Most infections in patients taking a ciprofloxacin for prophylaxis are gram-positive, which makes sense because it doesn't have quite as much gram-positive coverage as levofloxacin. So for patients who are unable to tolerate a fluoroquinolone, though, the NCCN recommends TMP, SMX, or a third-generation cephalosporin. So depending on the patient's chemotherapy, they may be at increased risk for CMV, HSV, or VCV reactivation for even months after treatment is completed. So rates of HSV reactivation, for example, in patients receiving purine analogs, specifically fludarabine, their reactivation rates approach 50% without prophylaxis. So patients with acute leukemia, just in general, are at high risk for viral reactivation, which is why viral prophylaxis is recommended. So an acyclovir and valacyclovir are good choices here. So fluconazole has good activity against Candida. It's a first-generation triazole. It's pretty cheap. It's pretty well tolerated, but it does lack activity against molds, and Candida resistance is emerging. Second-generation triazoles like voriconazole and posaconazole have expanded coverage, but they have significant drug-drug interactions and may cause more toxicity. So voriconazole adds some mold coverage, notably aspergillus, and is recommended as first-line treatment for invasive aspergillosis, but it has not been shown to prevent invasive fungal infections in a statistically significant way. Posaconazole, however, so adds protection against Fusarium and Mucor, and also covers Candida and Aspergillus well. Antifungal prophylaxis with good activity against mold is recommended in patients undergoing AML induction who are neutropenic. So given the broader coverage, posaconazole is an NCCN Category 1 recommendation for primary prophylaxis in patients undergoing induction for AML. So the echinocandins are an option for patients who can't tolerate an azole, but they are only available in an IV formulation. Patients with ALL, kind of different from AML, are not generally recommended to receive fungal prophylaxis with mold activity. So it's important to note, though, that these patients with ALL are still at intermediate to high risk for invasive fungal infection. Rates are like 3 to 12%. That this recommendation has a lot to do with the drug-drug interactions that we see with these second-generation triazoles with these mainstay ALL drugs like vinca alkaloids, alkylating agents, and tyrosine kinase inhibitors. So pneumocystis prophylaxis is recommended in several scenarios: allo stem cell transplant, ALL throughout its treatment, alemtuzumab for a minimum of 2 months following completion of treatment, prolonged corticosteroid use, and then you might consider it in purine analog therapy or other T-cell depleting therapies. The recommended first-line prophylaxis for that is TMP, SMX, and then atovaquone, dapsone, and pentamidine are alternatives. All right, moving on to DIC. So what is DIC? It's an imbalance between coagulation and bleeding. So we get this combination of thrombohemorrhagic complications characterized by deposition of fibrin in the bloodstream, and is always accompanied by another precipitating condition like acute leukemia or sepsis, liver failure, obstetric complications, transfusion reaction, pancreatitis, trauma, and snake bites. So thrombin and fibrin result in clot formation, and these clotting factors are consumed due to continued inappropriate clotting, and as a result, we can see bleeding. So platelets may also become trapped and consumed in this process. So in acute leukemias, DIC is particularly prevalent in acute promyelocytic leukemia, and is present in up to 100% of patients, kind of depending on what you read. So DIC is primarily associated with bleeding in the case of APL, while thrombosis is the dominant phenotype in ALL and non-APL AML. So in ALL, there was a 1992 study, so it's a minute ago, but about 12% of patients had evidence of DIC prior to treatment, and up to 78% of them experienced it during induction therapy. So in AML, FLT3, ITD, and NPM1 mutations have been independently associated with DIC. So the majority of AML patients who develop thromboses get them prior to treatment, and these can be venous or arterial. Then PEG asparaginase, which is used in ALL treatment, particularly in pediatrics, isn't a medical condition, of course, but it can cause disruptions in hemostasis that mimic DIC. And then we talked about infections, so bacterial endotoxins and sepsis can also precipitate DIC. So if we want to diagnose DIC, we first need to think about our patient's underlying conditions. So we're talking about acute leukemia today. So our patients are all at high risk for overt DIC. Bleeding is often the more dramatic physical exam finding, but remember that DIC is characterized by clotting. So we often don't see bleeding until after those clotting factors have been kind of used up. So we should also have high clinical suspicion for venous or arterial thromboses. And we can see evidence of end organ damage, like confusion, oliguria, chest pain, dyspnea, purpura, necrosis, even gangrene, depending on the location of bleeding or thrombosis. So we would want to check a platelet count, a prothrombin time, fibrinogen, and fibrin-related markers like D-dimer or fibrin degradation products. And these values help us determine the International Society on Thrombosis and Hemostasis DIC score. So the International Society on Thrombosis and Hemostasis has developed a scoring system for DIC to differentiate between non-overt and overt DIC using pretty readily available testing that is pretty easily interpreted. So you can see here that a lower platelet count, a higher D-dimer, longer PT time, and lower fibrinogen level is going to get you a higher score. So in this scoring system is like golf, the lower the better. So a score of 5 or more indicates overt DIC, and a score of less than 5 is suggestive but not affirmative of overt DIC. So we can continue to calculate this score kind of daily to gauge how our patient is responding to treatment. So what do we do about it? Treating the underlying cause is the mainstay of DIC treatment, and identifying a condition was part of the diagnosis, after all. So for our purposes, that generally means treating the leukemia, which can feel scary when platelets are low or patients are bleeding. And that, I think this is well exemplified by early administration of all trans-retinoic acid and APL. And it rapidly improves coagulation markers like D-dimer and fibrinogen, and delaying its start can contribute to catastrophic bleeding events and is associated with early death. So because we can't fix leukemia with just a couple doses of chemo, patients need supportive care while we get their leukemia under control. So this includes minimizing the risk of bleeding and transfusion of blood products. In the case of APL, NCCN guidelines recommend fibrinogen replacement with cryoprecipitate and fresh frozen plasma to maintain fibrinogen levels over 150 and keeping PT and PTT levels near normal until that coagulopathy resolves. So for patients with very low platelet levels, we may need platelet transfusion and even red blood cell transfusion if bleeding is extensive. Let's see, tranexamic acid is an antifibrinolytic agent that should be used with caution. It's contraindicated in the presence of hematuria, but we use it in my practice more as like topical treatment, like oral rinse, oral soak, gauze for patients to keep in their mouth who are having gum or other oral bleeding. For patients with extensive thromboses, intravenous or therapeutic subcu heparin may be required to prevent further activation of the clotting cascade. And that can feel counterintuitive if the urine's a little bit pink or there's oozing from IV sites. But anticoagulation can actually allow for reaccumulation of those clotting factors to either prevent or improve mild bleeding. So those patients who aren't bleeding should have prophylactic anticoagulation unless it's otherwise contraindicated. Non-pharmacologic interventions like avoiding invasive procedures, including placement of tunneled lines or portacaths as able, can help prevent bleeding. So we certainly see bleeding in leukemia patients undergoing high-intensity chemo outside of DIC. And in fact, 40 to 68% of our patients will experience chemotherapy-induced thrombocytopenia. So while thrombocytopenia is an expected finding associated with treatment, bleeding isn't necessarily. So randomized trials can be difficult to come by, and a lot of protocols are driven by institutional or provider preference. That being said, these are some kind of general rules of thumb for management. So prophylactic transfusion for platelet counts of 10,000 or less is recommended to prevent spontaneous bleeding. In APL, higher platelet thresholds should be maintained due to that higher risk of bleeding that we talked about. Which does contribute to early death in this population that otherwise has really good survival rates. So NCCN recommends a platelet threshold of 50,000 in the case of APL, while recognizing that there's a lot of variation among institutions. So surgical bleeding can be seen at higher rates at platelet levels less than 50,000. So that may be a goal prior to invasive procedures. I find that I kind of just have to let my surgery colleagues tell me what they need the level to be, kind of based on their comfort level and the patient's clinical status. So then blood products should be leukocyte reduced and irradiated. Leukocyte reduction is just what it sounds like. It removes most leukocytes from donated blood, thereby reducing the risk for febrile transfusion reactions and alloimmunization to HLA donor antigens. And reduces risk for infections like CMV. So irradiation uses X-rays or gamma rays to inactivate any remaining T lymphocytes in the donor blood, which thereby helps prevent transfusion-associated graft-versus-host disease. All right, moving on to tumor lysis. So TLS is characterized by massive tumor cell death, which leads to the development of metabolic derangements and organ dysfunction. So intracellularly stored electrolytes and other cellular contents are released extracellularly when tumor cell lysis occurs. So the accumulation outpaces cellular buffering systems and excretion by the kidneys. So it's considered an oncologic emergency due to the risk of rapid progression of life-threatening complications. And TLS most often happens in hematologic malignancies due to the high rates of cellular division. It can occur spontaneously or after exposure to chemotherapy. These highly proliferative disease states tend to be very sensitive to treatment, and the incidence is rising due to the development of targeted therapies that are highly effective at killing these tumor cells, even in disease states where we didn't historically think of TLS, like chronic lymphocytic leukemia and solid tumors. So it most often occurs 3 days prior or up to 7 days after the administration of chemo. And we traditionally see TLS with chemo, but it can occur with corticosteroids, radiation, hormonal agents, and antibodies, and even can occur with procedures like biopsies, embolization, and tumor surgeries where the tumor is disrupted. So having high suspicion for TLS is key to preventing potentially life-threatening complications. Understanding who's at risk helps us initiate prophylaxis early, recognize these metabolic derangements if or when they occur so we can address them promptly. We can diagnose TLS based on laboratory or clinical findings. So Cairo and Bishop developed probably our most widely used definitions of TLS, and that's what's kind of adapted here. So lab findings include elevated potassium, uric acid, phosphorus, as well as reduced calcium levels. So it's possible for this to be a silent phenomenon without clinical manifestations. And 2 or more of these lab abnormalities must be present to call it TLS. So elevated potassium is typically the first abnormal electrolyte to appear. Uric acid becomes elevated as a result of nucleic acids being metabolized after that cell death has occurred, and those contents have been kind of dumped into the bloodstream. Hyperphosphatemia can lead to formation of calcium phosphate complexes that can precipitate out into the tissues, notably the renal tubules. So calcium drops as a result of being bound to the phosphate complexes, which can cause hypotension, tetany, muscle cramps, cardiac arrhythmias. An international expert panel in 2010, which included Cairo, actually did not include low calcium in the criteria for diagnosing TLS, as it's not always felt to clearly be a consequence of the TLS. Clinical manifestations include renal, cardiac, and neurological complications kind of related to these metabolic disturbances, which can be life-threatening. So other signs and symptoms that we may see clinically can include nausea, vomiting, shortness of breath, cloudy urine, lethargy, joint discomfort, and loss of muscle control. So that's what we're looking for in TLS, but who are we looking at for it? Low-risk disease describes patients with less than a 1% risk of developing TLS. Intermediate risk confers a 1 to 5% risk, and high-risk disease corresponds to greater than 5% risk of developing TLS. So this tool kind of helps take into account the disease state, the white blood cell count, and LDH. So patients with AML and a white blood cell count of 25 or less with LDH less than 2 times the upper limit of normal are considered to have low-risk disease. But if the LDH is over 2 times the upper limit of normal, it's considered intermediate. White blood cell count of 25 to less than 100 is also intermediate. If the white blood cell count is 100 or greater, it's considered high risk for TLS. So patients with ALL, and remember, lymphoid cells are much smaller than myeloid cells, so we can tolerate a much higher white count without running into as many problems. But so in ALL, if the white count is less than 100 and the LDH is less than 2 times the upper limit of normal, they're at intermediate risk for TLS. If LDH is greater than 2 times the upper limit of normal, with the white count still less than 100, they're considered to be high risk, as are patients with white counts of 100 or greater. So we may choose to debulk with steroids or hydroxyurea, or kind of smaller doses of chemo before we start our preferred regimen, to mitigate some of this risk. Leukapheresis should really be reserved for symptomatic hyperleukocytosis, and hasn't been shown to reduce early mortality or rates of TLS or DICE, or to change overall outcomes. So prevention of TLS is key, kind of like with infection. The cornerstones of management are aggressive hydration, addressing hyperuricemia, and frequent monitoring of electrolytes to allow for timely correction if aberrations are noted. So recommendations for the frequency of lab monitoring vary, but I think starting at every 6 hours is reasonable. So aggressive hydration. We want to avoid potassium, phosphorus, and calcium-containing fluids, since these electrolytes are or may become abnormal. So this includes lactated Ringer solution, Plasmolite, and Normasol. Kind of plain old normal saline is great in this situation. We need to flush the pipes. So in patients with high to intermediate risk TLS, or risk for TLS, we want to keep urinary output greater than 100 mLs per hour for 24 hours before starting chemo, if that's possible, and throughout the duration of treatment. If urinary output lags, loop diuretics are recommended with continuation of the fluid. So we're probably among the only specialties that use fluids and diuretics simultaneously. But we should pay particular attention to patients with cardiac or renal dysfunction, and the elderly who may need some extra help to eliminate this volume. So thiazide diuretics should be avoided, as they can increase uric acid levels and interact with allopurinol. Historically, alkalizing the urine was recommended in tumor lysis, to increase the solubility of uric acid, thereby reducing crystallization. The problem with that is that it can increase the precipitation of calcium phosphate, and is no longer recommended, since we're essentially causing the same end complication that we were supposed to be mitigating. So managing hyperuricemia is important in prevention of acute renal failure by preventing or reducing uric acid crystal formation in the renal collecting system, which can cause obstruction. Avoiding renal failure is particularly important in TLS because we want to make sure we can eliminate those electrolytes like potassium, which may become high, and can cause life-threatening dysrhythmias. So maintaining hydration is protective, as we discussed, but uric acid lowering medications are essential as well. So allopurinol is a xanthine oxidase inhibitor that prevents the conversion of xanthine to uric acid. So it's much more easily cleared by the kidneys than uric acid. It's pretty well tolerated. It can cause rash. And the one drawback is that it does not reduce uric acid levels. It just keeps them from climbing higher, while your body kind of gets rid of those waste products. Febuxostat is also a xanthine oxidase inhibitor that's been shown to offer a greater reduction in uric acid compared to allopurinol, but no difference in the incidence of TLS when used for prevention. But there's no dose adjustment for renal impairment, which may make it attractive as an alternative to allopurinol in some patients. Rasburicase is a recombinant urate oxidase, which uses an enzyme that metabolizes uric acid in many other mammals, but not in people. So it's highly purified, but hypersensitivity reactions are possible. It has fewer drug-drug interactions than allopurinol, and it doesn't require dose adjustment for renal or hepatic dysfunction. It also provides rapid and significant reduction in uric acid levels. So it's a good option for patients with spontaneous TLS or whose uric acids aren't responding adequately to something like allopurinol. So it's important to note that rasburicase can continue to reduce uric acid at room temperature. So blood samples should be kept on ice and ideally analyzed within 4 hours of collection so that we avoid kind of falsely low levels. The FDA approved dose is weight-based, but subsequent studies have shown that actually single flat doses are also effective, which is a significant cost savings if we're talking about a 100 kilogram patient who might get a 20 milligram dose versus a one-time dose of 4.5 milligrams that is still effective. Asymptomatic hypocalcemia should not routinely be treated to avoid causing precipitation of calcium phosphate crystals. Loop diuretics can help address hyperkalemia as long as we're not causing hypoperfusion of the kidney. Calcium gluconate may be indicated if potassium levels are 6 or greater to help stabilize that cardiac membrane, or if EKG changes are present and are attributable to hyperkalemia. IV insulin and glucose can be used. The insulin helps drive potassium intracellularly, and then glucose is given to prevent hypoglycemia in your patient who probably doesn't need exogenous insulin for glucose management. And then beta adrenergic agonists like albuterol could be added, but are not recommended as monotherapy. They also stimulate cellular uptake of potassium. So oral cation exchange resins like Kxalate are kind of inconsistent and often take too long to reduce potassium levels in this scenario. Renal replacement therapy is really the most reliable way to bring the potassium down to a safe level and keep it there. But it's also our most invasive intervention and should really be utilized only in patients who we can't manage effectively with medication. Hyperphosphatemia can be difficult to manage, especially if it occurs in conjunction with acute renal injury. Oral phosphate binders can be used if the patient can tolerate PO, but it's also most effectively managed with a renal replacement. So once there's no tumor lysis. So balancing treatment of the underlying leukemia with prevention and treatment of TLS can feel like kind of a nebulous judgment call with regard to timing and drug choices, kind of a real collision of the science and art of medicine that makes managing these patients difficult, but also rewarding, I think. Well, thanks for your attention. I hope you feel like you know a little more than you did before about managing infections, DIC, and TLS.
So we have a handful of questions from our audience member, and I think they're mainly focused around the number of blood cultures you draw at the initial presentation of neutropenic fever. So let's walk us through if somebody has a central line and had a neutropenic fever, how many sets of blood culture you draw, and if somebody does not have a central line, how many you suggest we do?
Yeah, so I think we should shy away from just obtaining one set of blood cultures. That kind of greatly reduces the sensitivity of finding an infection. So for somebody with a central line, we would be concerned that potentially that line has been infected, which is why we would want a set from the central line. And when I say set, I mean an anaerobic and anaerobic bottle. So I would be curious about the cultures from that line. Sorry. And then would also get a peripheral set as well. So if there's no central access, then I would want at least 2 peripheral sets of cultures.
Okay, and do you suggest, so one set, and I think the reason for confusion might be that when we say set, it means one aerobic and one anaerobic bottle, correct? Okay.
Yeah.
So when we say that we want 2 sets of blood culture in a patient with central line, that means that we want 1 set from the peripheral stick and the 1 set minimum from the central line.
Yeah.
Correct. Okay. Now, how about somebody who has triple lumen catheter? Would you suggest we draw 6 bottles or 2 bottles from each lumen? How do you handle that?
Yeah, typically in my practice, we just get 1 set from the peripheral, or excuse me, from the central line.
Okay.
Do you guys do it differently?
No, I think we do the same. I was just going through the IDSA guideline while actually your talk was going on. Last they were updated in 2011, so they align with our practice actually, which is recommending one peripheral and 1 central set of blood culture. But they do suggest to send one set from each lumen, which was kind of interesting. Not sure what's
interesting
behind that.
Yeah.
Now, if somebody, of course, you did a set of blood culture at the time of diagnosis, you put them on broad spectrum antibiotics. So in our case, our to-go antibiotic is cefepime. And this particular patient continues to spike fever on a daily basis. So when you would repeat the blood culture, and when you repeat the blood culture, do you do the same again, central plus peripheral, or you just send the central? So that's question 1. The second question is, at what point you stop, because we have been in the situation where leukemia patients, neutropenic, we don't expect their counts to recover for weeks on, and they keep spiking temperature for days on. And of course, we do scan and other workup for fever, but do you keep doing the repeat culture forever, or you stop at some point?
Yeah, I think in my practice, we often will kind of let our infectious disease colleagues give us their blessing to stop checking blood cultures. I think in my practice, we will wait at least 24 hours in between cultures. Maybe we would draw more if the patient was really decompensating, but in general, we wait at least 24 hours before reculturing.
And do you repeat both peripheral and central, or next time in the repeat, you just do the central line culture?
Typically, we'll repeat the central line and peripheral.
Okay. Yeah, so I'll add a bit of a comment here, because I practice on a stem cell transplant unit where Whitney is our lead APP in our AML, ALL unit. So on a stem cell transplant, we tend to only repeat the central line cultures for a recurrent fever, and we generally stop doing the cultures after 2 to 3 days if the patient continues to spike fever. But if otherwise asymptomatic and hemodynamically stable, we of course broaden the infectious workup per guidance from the ID, to the fungal study, pan imaging, looking at the sinuses, chest, abdomen, trying basically like go down the road for like more atypical infections. So there's definitely some variation in the practice, even in our single hospital. Let's see. I encourage all the audience member, by the way, to keep sending the questions. Let's see. So next question is somebody with diarrhea. How often you actually do the stool culture? Of course, the C. diff and the GI panel are common, but do you ever do a stool culture?
And you guys on transplant, Dr. Delaria, probably do more than we do. I would say that we image more than we get stool cultures. Like we would get a CT of the abdomen, maybe, to check on diarrhea symptoms. But we check a lot of C. diff and the GI pathogen panels.
Yeah, so I think it really depends on your level of expertise at the local lab. So we are kind of spoiled here at Vanderbilt because we have this broad GI pathogen panel, which is a PCR assay, and it tests like almost like 10, 12 different pathogens in a single stool samples. And it pretty much covers whatever the organism, the common culprits. So like, E. coli, Shigella, Salmonella, bunch of viruses. So it picks up a lot of things and definitely much more sensitive. And the results comes within 24 hours. So where the cultures can take days. In my experience, I have personally almost never used stool culture unless the infectious disease doctor have asked me to do one, because most of the time we are able to pick up the culprit organism if this is an infectious diarrhea. As we know, most of the time when a chemotherapy patients have diarrhea, it's just because of chemotherapy and there's no infection. And the C. diff is our #1 pathogenic cause of diarrhea in our center, at least. So, but depending on your local, of course, the common etiology. So if you live in a hospital where the E. coli outbreaks are common, then I think it's worth doing a stool culture in that situation if you don't have access to this PCR panel. The next question is, when you consider removing a central line if the patient's cultures are negative and continue to spike fever, would you consider doing that?
Yeah, that's a good question. If we had a high suspicion that the line was infected, I had read, I think Mayo did a study where 2 sets of cultures only had an 80%, like only detected 80% of bloodstream infections. So it's certainly still possible that your patient has a bloodstream infection, even if we don't see positive cultures. Gosh, I don't know. I hate taking out central lines, particularly like a port or something that's a little bit more invasive.
Yeah, I would say it's a judgment call for sure. I have pulled out a fair share of central line in my practice, but I only do it if there is, of course, an obvious signs of infection. Like if I worried about there's like a cellulitis or like a drainage around the catheter insertion site, or patient is having a tenderness along the tunnel catheter. Or if the patient is like hemodynamic unstable and we just can't figure out where the fever is coming from. I can tell you the success of removing a central line and fever resolution is not that great. So many times we just empirically take the line out and send it the tip for the culture, and really nothing grows because these patients are already on broad spectrum antibiotic by the time we make a decision to take the line out. So I would say it's clinical decision on a case by case basis, but I'm very cautious in putting patient through a surgery, especially if it's a port, because these patients are, of course, not only neutropenic, but they also have very low platelet count. They're coagulopathic. So many times, if you try to remove the implanted port, it can lead to more problem than the solution of the fever, like a bleeding or more infection. So I would be very careful. But if it's just a PICC line, which is easy to remove, I think we have a low threshold of pulling the PICC line out because it's easy to put back in if we need to. I think we answered this question. There's another question is, yes, the slides and the whole recording will be available on ISCH website for the later viewing for the audience members. So yeah, this will be there hopefully forever. I have a few questions, I think now pivoting a little bit from the infectious complications, which are of course very important and very common. But I would like to hear about some of the newer drugs which we started to use, especially the IDH inhibitors and menin inhibitors, which leads to differentiation syndrome. So especially in acute myeloid leukemia patients who receives this drug, can you tell us a little bit about our practice? Do we do anything to especially monitor this patient who we are worried going to have differentiation syndrome? And what are the common signs, symptoms, and maybe a few lines about treatment approach?
Yeah, so differentiation syndrome can occur when we, like you said, when we use IDH inhibitors. They kind of force these leukemia cells to differentiate. And oftentimes they'll go to the lungs and cause respiratory symptoms, cause fevers, shortness of breath, hypoxia. So for patients with like high burden of disease who we think may develop this complication, we can use steroids prophylactically. And then if they do develop differentiation syndrome, steroids are the treatment also.
Okay. Yeah, I think and more targeted drugs are coming down the pipe for the AML, and many of these agents are associated with significant risk of differentiation syndrome. So I encourage audience member to read the package label, because most of these drugs have the warnings that it can cause severe differentiation syndrome. So other point I wanted to touch base with Whitney today was kind of doing the Blincyto for our ALL patient. You know, we admit them right now for the hospital for the first cycle or so. Can you walk us through the process of kind of monitoring these patients and some of the unique toxicity we see with this drug?
Yeah, so blinatumomab is a bispecific antibody. So it does have kind of unique side effects to traditional chemotherapy. The neurotoxicity is unique. Patients can get confused. They can have headaches. It can progress to something as severe as seizures, coma, death. So that is a little bit different than some of our chemos. Let's see, also just in administration of Blincyto, it requires a very slow rate of infusion. If it's interrupted for more than 4 hours, we have to kind of pre-medicate them. Because it has to go in at such a slow rate, we don't flush those lines. I know there were a lot of nursing considerations kind of when we first started using it that were kind of just something to get used to. But yeah, so the neurotoxicity and then cytokine release syndrome, which we see with CAR T, but also with these bispecific antibodies, where patients can get fevers, hypotension.
And who manages the pump at our floor here? So of course we have like the computerized order system, but if somebody has like in the middle of a night CRS or neurotoxicity, and the nurse like can you tell us a little bit about who manages in the middle of the night?
Yeah, so I am lucky and I only have to work during the day, but so typically we'll pause the infusion. We give steroids for that toxicity. And then it's usually somebody like you, Dr. Deloria, is getting a phone call if it's in the middle of the night.
Yeah, and of course, for the audience member, it's very important that whenever you decide to resume the infusion of Blincyto, please work with your chemopharmacist, because there are very strict rules around at what infusion rate to resume it and how to escalate depending on the toxicity and at what level the toxicity happen and the degree and severity of the toxicity. So there is a table actually in the Blincyto package insert if you guys want to have a ready reference. So last few questions before we wrap this thing up. You had a nice slide about the DIC scoring. So the question is like, are we doing it on a daily basis or how often we do it? Just practical.
Yeah, the recommendation if there, and I have to look it up every time I use it, that rescoring daily if they are continuing to score high. But a lot of it is really just like clinically, what do they look like? Does the oozing seem less today? Kind of around IV sites. Is their fibrinogen any better? Kind of that's generally how I use it.
Yeah. And one more question from the audience was like using the lock therapy with vancomycin for CVL infections. I have seen this being done more and more often. I'm not sure what's your experience is. This is for confirmed infection.
For confirmed infections, yes. And usually the infection, usually the infectious disease team is kind of driving that. If they've determined that we can, that if we can try to salvage this line, then we can lock it with vancomycin, have it dwell in the device, and hopefully be able to take care of the infection that way.
Okay, thank you. I think we kind of pretty much covered most of the questions from audience member. I really appreciate everybody hanging out with us this morning, evening, afternoon, wherever you guys are in the world. This talk will be saved on ISCH website, and it's very easy to find our email addresses from the Vanderbilt website. So if you guys hear our talk and have any additional questions, please reach out to Whitney and myself. Happy to help out whichever way possible to take care of our leukemia patients. So thank you so much, and have a good rest of the day.
Yeah, thank you.